And it's a pleasure to introduce our first speaker, Angélique Stéphanou, from CNRS Laboratory and the University Joseph Fourier in Grenoble. So Angélique did a PhD in Dundee many years ago, and then did some postdoc in Heriot Watt. I should have added Angélique's name to the list of collaborators on the angiogenesis stuff. But this afternoon, we're all looking forward to hearing your talk on an integrated computational approach for the design of patient-specific virtual tumours. Angélique.
So thank you for the invitation to give this talk. So I have to thank. Oh, sorry. Okay, so I want to thank Mark for the very nice talk of this morning because he did most of the job, so it will be shorter, much shorter for me. So I won't have to discuss a lot about angiogenesis. So what I'm going to talk about is a model we try to use to create a virtual tumor so that we can test the therapy on the virtual tumor and make it easier then to derive the right treatment for the right patient. So the context is the following. Many progresses have been still not working. Oh.
So that is for the recording.
Yes.
To hear you have to speak up.
To speak up.
It's not a microphone. It's just for the recording.
Well, it does work as a microphone.
Higher up. Yeah. Okay. Yeah. Is it better? You can hear me? Or? Yeah. Okay. Sorry. What's this noise? Oh, it's outside. Okay. So many progress has been made in cancer therapy over the past 10 years, and we have a wider range of therapeutic options, more specific molecules, so that we can reduce side effects and even more individualize the therapy. However, when we apply a therapy, the tumor development becomes much more complex because now we cannot predict what's going to happen. So what we observed is some strong resistance to treatment and also some selection of more aggressive phenotypes. And so the new objective is to try to rationalize the use of the therapies to be able to predict what's going to happen and to be able also to combine the therapies to enhance some effects and to adapt the therapy with the evolution of the tumor, of course, and the patient states. So why do we need a virtual tumor? It would help to provide an integrated vision of the overall phenomena, and it will give the ability, of course, to make the virtual experiments. And so we will be able to test some hypotheses to better understand the system, and above all, to predict the system's reaction, and also to optimize some solutions. So I will briefly go back to the development of a tumor. So Mark already explained most of it very nicely this morning, so that will be short. So the tumor starts to develop avascularly, like this, and it reaches a size of about 2 millimeters, and then it starts the cells become hypoxic, and so they start to release some growth factors, mainly VEGF, that diffuse in the environment, and it is detected by the endothelial cells forming the vessel walls, and so the cells detach and they migrate toward the source of VEGF, and so we have the vascular growth of the tumor in the second stage. So VEGF induces the angiogenesis. And at this stage, the tumor becomes much more dangerous because some tumor cell can escape from the main tumor and go to invade so we've seen it this morning, it's a tumor metastasis. Then, okay, so escape from the tumor mass. So if we have a look at normal and tumoral vascular network, we already mentioned this morning that they are very, very different. So the normal network is very organized, and it's mostly impermeable vessels, and there is a very large pericyte coverage in red here along the vessels. So the pericytes maintain the impermeability of the vessels. And in a tumor network, it's very different. So we see the structure is very dense and disorganized, abnormal, with dense and tortuous vessels. And it is very permeable, and it's mostly related to the fact that there is no pericyte coverage on the vessels. So it becomes very leaky. So that's how we can distinguish the two. Sorry. So in this study, what we wanted to do is to investigate the coupling of two molecules, and what we were looking at are the vascular disrupting agents that are directly targeting the vessels, and some cytotoxic molecules that target the tumor cells. So to reach the tumor, the cytotoxic molecules need to go through the vessels, through these vessels. So what we already saw that this morning, that Volkmann predicted that if we could cut the vessels, then we could kill the tumor by starving it, by depriving the distribution of nutrients and oxygen. But what we observed when the first treatment were applied is the exact opposite. The tumor, instead of stop growing, they keep growing at even very fast. And what we observed, in fact, is the normalization of the vascular network. What we did is that we just cut the smaller vessels, the tiny ones, but we kept the bigger ones, the motorways in a sense. And so the delivery of nutrients was much more important, and the tumor would grow even bigger. So as Mark mentioned it this morning, it can be a thing that we can exploit to increase the delivery of cytotoxic to the tumor. So the idea is to try to use these vascular disruptive agents that normalizes the network, and with the right timing, then we can use it to deliver the cytotoxic molecules, and so we have this therapeutic window that we can exploit to maximize the effect of the therapy. So the whole point of this project is to try to do that. So to do that, what we do, we wanted to put in to try the concept of computer-assisted therapeutic strategy. So the idea is the following. We have a real tumor. We make a parameterization of this real tumor to create a virtual tumor. Then we can optimize and simulate the therapies on this virtual tumor, make all the tests that we need. And then when we identify the optimum therapy, then we apply it to the real tumor and we observe the results. So so this is the tumor size, so we expect that the tumor size is going to decrease. So when we observe the tumor, we see its evolution, and as long as the two curves, the prediction of the virtual tumor and the observations are okay, then we go on applying the treatment, and as soon as we see some divergence, then we go back and we change the initial state. We replug a new initial state for the virtual tumor, and then we start all the process again until we get rid of all the tumor cells. So to do that, we need to have an experimental model where we can see how the molecules are acting. So what we first use, so the experimental model 1, it's the dorsal chamber, so the one that Mark showed this morning. And so it's a very nice device because we can indeed see the tumor developing and all the vasculature around. So we see that the growth of the vessels and the dilation of the vessels and all that, and even the tumor growing. The problem with this is that it's not as good as it is, in fact, because most of the mice, they die because of the device they are wearing and not because of the tumor. So it's a very invasive device. So we wanted to use it, so we used it, and we used it as far as we have been able to validate the model with this. But when we apply the therapy, then it can't work, because the therapy, we hope that the mice to live for at least a few months, and the time limit is about 3 weeks. So we had to think of a new device, a new model. So the new model is the same, in fact, but this time we put the tumor in the ear of the mice, which is a very thin structure, so we can see through, and it's very nice because it requires no surgery. So we don't have any inflammation, and the mice are completely all right with that. There's no complication, nothing. So, and we can do very nice imaging with this device. So we use microfluorescence imaging that we could do also with the dorsal chamber, but it's even nicer in this device. And what we can see here is the tumor mass. So for that we use some transfected cells, tumor cells transfected with the green fluorescence protein, so that we can see it here. And the vascular network, so to image the vascular network, what we do is that we inject some dyes which are dextrorhodamine, which is fluorescent in red. And so when we inject this fluid, then we can see it highlights the vessels around the tumor. So we can see the two structures. And so we can switch the channels and only observe the tumor and to have only the tumor cells, so that we can see the effect of the cytotoxic molecules that target specifically the tumor cells. And we can switch to the other channel, the red one, to see the effect of the vascular disrupting agents on the vasculature. So, okay. And what we want to look at is the synergetic effects of the two molecules on this system. So now I'm going to talk about the model, the building of the virtual tumor. So what we use is a cell-centered hybrid multi-scale model. So I don't know in which order we should put these things, but it's all there. So it means that it is centered on the cell, so we use cellular automaton to describe the behavior of the cells. So it will mean that we describe both the cells forming an angiogenic network and the tumor cells. And this is plugged to diffusion of chemicals. So we've seen this morning already that there are plenty of chemicals interacting in this model. And we can also integrate some intracellular dynamics, for example, to integrate some elements of the cell cycle to see how it can affect the behavior of the cells. And then we have some connection. The cell responds to its environment and all that. You want to switch off this one? Okay. Is it possible to switch off this one? Okay, maybe it's better. Yeah. You could not see anything before? Okay. So the computational model, in fact, has two main modules. So the first one is a tumor growth module, and it can take into account metastatic invasion, but at this stage we do not implement this. But we have in this tumor growth model some element to describe the cell cycle, the metabolism of the cells, and the death of the cells. And we plug this with it interacts with another module, which is the angiogenesis module and vascular adaptation. So this one, you had all the details already this morning with Mark's talks, because it's the exact same model that I'm using. So it integrates some element of vessel permeability also, of diffusion of therapeutics and molecule and oxygens. So we use this model, these two modules that I will now present. So the cellular automaton looks like this. So we plug the cells on a grid. So there are two superimposed grids. In fact, it's the same grid, but we use the edges of the grid to model the vessels, and the element of the grid to model the tumor cells. And there are interactions in between the two systems. Okay, so for the angiogenesis modeling, I will be very quick because everything has been said this morning. And so the tumor vascularization developed through the extracellular matrix in response to the growth factors and it has to cross through the matrix of fibers. So we have initially some parent vessels, the source, and we have some probability for the vessels to move around. So I won't go into more detail in this. And so we make the simulations and see how the VEGF guides the endothelial cell migrations and how the proteases degrade the matrix. And so it keeps on expanding and dividing and branching with all the hypotheses that we saw this morning. And recently in this model we implemented some sensitivity to the matrix mechanical properties, because we wanted to explain how the vessel could meet in a 3D structure, which was not obvious from the previous model. So we implemented that and it works quite fine in integrating these mechanics. So it's a recent study. And we go on growing the network, and the VEGF so stimulates the proliferations. And at the end, what we see is some discrepancy, because here it's a very homogeneous network, and here it's very heterogeneous. So we have to flow it, in fact, to have this structure with the bigger vessel and smaller ones. But we can also grow it as it flow it as it grows. It takes more time. So we use the exact same model. So recently we made some changes in the model. We changed these terms that we could interpret like the contractility due to the presence of pericytes around the vessels. So they are contracting the vessels to prevent it to expand. And in fact, this is very sensitive to the VEGF, because when the VEGF is here, then the cells detach, the pericytes, they go away. And so the dilation is much easier in presence of VEGF. So we change this term to incorporate the effect of VEGF. So once we have the blood flowing into the vasculature, then it's possible to derive the tissue oxygenation. So we just put we have some red blood cell flowing in it, so we have some transmural pressure of oxygen, and so we can calculate the diffusion across the vessels of this oxygen to have the tissue oxygenation. Okay, so I will just now describe how we take into account the diffusive species in the model. So what we have are proteases. So they are the matrix degrading enzymes that are produced by endothelial cells to migrate through the matrix here. So we have continuous equations, but with some individual cell acting on some of the terms of these equations. So they can either produce some chemicals or consume some chemicals. So that's what we see in here. And we also implemented the vascular degrading enzyme, because at some point the vasculature is degraded due to plenty of different things. It can be enzyme, but it can be also an increase of acidity around the medium, around the tumor. So we wanted to implement that, and it's quite a very important phenomena, in fact, the degradation of the network. So I'm not sure it's the best way to take it into account, but it's the first attempt that works quite fine for the moment. And we also have some growth factors. So here we see that it is produced by the quiescent cells. So in our model, in fact, we assimilate the quiescent cells to the hypoxic cell, which is not true, but it's a simplification. And we also model the oxygen, which is, so the oxygen can be consumed by the different types of cells. So here it just means that the rates are different depending on the type of cells. So the proliferative cells, they consume much more oxygen, for example, than the quiescent cell. And we have also another term, which I will not develop here, which we call the vessel weight. And in fact, this term wants to take into account the role of the vasculature. It means that when the vasculature is very dense at some point, then this weight will be high, and when it's not, then it will be low. So so when, for example, here when the vessels the weight is high, it means that we will have a higher concentration of growth factors. And here, when the vessel is high, which means that we have a higher diffusion of oxygen delivery. Okay. So the next part of the module, then I described this one. So now I'm going to describe the tumor growth and metastatic invasion. So in our model of tumor growth, we take into account different kind of type of tumor cells. So with different colors. For example, here the black ones are the necrotic cells, the dead cells mainly, and the lighter ones are the proliferative cells, and the gray ones are the quiescent cells that are producing the signal for angiogenesis. So yeah, VEGF. So the automaton is obeying these rules. So this is connecting all the different type of cells, so proliferative, quiescent, necrotic, apoptotic. So what we see first when we implement some treatments, we look at the proliferative cells, and if there is some therapy, and if it's the lethal dose, then the cell is going to die. And if not, then it must be in a phase. It must be sensitive to a specific phase that the treatment is able to act on, which and then we look if there is enough oxygen. If there is enough oxygen and the cell is in a sensitive phase for oxygen, then if there is enough oxygen, then it can go there and proliferate and go back through this loop. And when there is not enough oxygen and the cell is in a phase of this cycle where it is sensitive to this lack of oxygen, which is here the cell cycle, it's the G1 phase, which is mostly the phase sensitive to the lack of oxygen, then it can go to G0, which is in the fact the state of hypoxia, of quiescence. So the cell, when the oxygen is leaking, is going here into the quiescent state. And so it can stay in this quiescent state for some time, but there is a time limit above which it cannot resist anymore and die through necrosis. And if the oxygen levels come back to normal, then it can go back to the proliferative state. And okay. And there is one other important point in this automaton is when the cells, they can proliferate, they want to divide, so they need to have some empty space around to be able to divide. So we have to look, so it's when it is the M phase for mitosis. Is there enough space? If there is, then it can divide, and so we have two proliferative cells, and if it cannot, then it dies from apoptosis. So there are two different kind of death in the cells. We have the necrotic and the apoptotic death, and so the difference is mainly that necrotic we don't remove the cell from its element in the automaton, whereas in apoptotic cells there is some signaling of the cells when they are dying, and so they are removed by macrophage, and so the element of the automaton will be freed. So that's an important difference, in fact. Okay. So what we do is we use the model, the first experimental model, the one with the dorsal chamber, to try to validate this model, and without treatment in the first stage. And it worked. We were quite happy with it. We needed to adjust some things, but it was okay. So first what we did is to compare the simulation with the observed kinetics of tumor developments. So you see here that the tumor appear with different size, and this is due to the fact that experimentally we inject the tumor cells in a matrigel. So the matrigel is taking a lot of space. That is why it appears much bigger. But in fact, there's the same amount of cells in the two. And so we observe the experiment, and what we see is the first stage we have some strong vessel dilations here, some vessels that are dilating, and then after some time the dilation comes back more or less to normal, depends where, and what we have is the beginning of angiogenesis. So we see some small vessels appearing around the tumor and inside the tumor. So we could more or less capture these two events, the first stage of vessel dilations and then the angiogenesis occurring at a later stage with the same order of the same kind of kinetics. So then we, as I said, we could not use the dorsal chamber for a long time because our mice were dying too quickly. So when they were dying, then we removed the tumor and performed some histology. And so we could compare with the later stage of the tumor models some data. For example, we could look at the oxygens. So it is possible to highlight where the hypoxic cells were in these regions. And also we can look at the degradation of the matrix in the tissue. And just we have another way to compare the experiments with the models with some experimental data. And okay, so the last thing, so we use this model, this experimental model, to adjust all our parameters and to validate our hypothesis. So the parameters that we had to specifically adjust were the duration of the cell cycle phase and the level of variability in between the cells. We had to adjust the oxygen thresholds for the transition to quiescence and for cell death also. We had to adjust the oxygen consumption rate for each cell type, and this was a very tough thing to do because all these data, there are very few data in fact in the literature that correspond to the exact same model, so we have to make some guess. And also for the vessel permeability to oxygen. And so we did it. This was not implemented in the first version of the model, and there was something wrong because the tumor was always growing and growing and never stopping, and it was due to the fact that we did not destroy the smaller capillaries in the in the tissue. So we had to take this into account. So as a first try, what we did is to implement the vascular proteases, something to degrade this underlying vascular network. So we had to guess the diffusion, production, and consumption rates of this element. Okay, so then we managed to have our model calibrated for our experimental model. So we used the experimental model 2 this time on the ear of the mouse, and we made some images. And what we want to do is now to create a real virtual tumor. So to do that, we have the original GFP image. So now it's gray, it's not green, but it's a green image we saw before. And what we did is that we apply some intensity thresholds to what we really want to do is to capture the different densities of tumors in this one to recreate them virtually. So it's a way to do it, to apply different thresholds, so with different increasing thresholds here to get some 3 different images. Then we add some noise to each of these images. So this one has been here, is here, this one here, and this one here. And when we have these 3 levels of noise, then we make an addition of these 3 images, and we got the results, which is the starting point for the virtual tumor. So, and we can capture here, you see the high density zone here, and some lower here, and very light zone here. So, okay, because yeah, in this model I have to say that we are working for the moment in just one slice, so it's a 2D model. And we do the same kind of thing for the vascular network. So what we take a bright field image when we can see the bigger vessels, then we take the skeleton of these bigger vessels, then we crop the image to the size of our simulation tissue, the simulated tissue. Then what we do is that we perfuse these vessels with the model that Mark presented this morning. So we have some dilation of some vessels and some contraction on some others. So we wait steady states, and when we got it, then we can put the tumor cells in the framework, and we have the starting point for the virtual tumor with the exact same vascular network and the exact same density of cells. And then we can run it, and we have the real and virtual tumor. So this is the real one. So this is the starting point, the initial condition here. And from then the model is not adjusted anymore. We let it live its life, and we observe just at some discrete time points if it fits or not. So we see that we have some nice agreement for the size and shape, and also another parameters, which is the texture, but I will describe this later. So we can also compare if we use the bright field images, where we can see the shadow of the tumor and the vessels. So we can reproduce the same kind of pictures with the simulations. And here we can see the angiogenic network developing around the tumor here, and here some patches of proliferative cells. So if I add some VEGF, we see what's happening. So we can have access to hidden information with the virtual tumor, so something that we cannot see in the experiments. So here we see how the VEGF is expanding around the tumor due to the quiescent cells. And here we see the patches of proliferating cells where the angiogenesis is the highest. So we can switch to the channel for oxygen diffusion, and we see the dark patch are hypoxic tissue, and here the bright blue are the region where the oxygen was delivered to the tumor. Okay. So as I said, there's not only the size and shape of the tumor that matters, but also the texture. And we thought of some way to try to highlight this change in texture, because what we see, as I said, we work with a 2D slice, but in fact what we see is the integration of a 3D tumor. So what we see, which is dark, can be some cells, but in a different plane on our picture. So what we do is that we plot the normalized number of pixels depending on the level of brightness. So here, for example, in day 3, what we see is that we have a lot of dark pixels and very few bright pixels. And with time, we see that the curve is progressively changing and turning to this green last curve, which is nearly all the level of pixels are present, and we have some slightly more brighter pixel at the end. So we have this sliding movement of the curves in here. So we thought that we could not use it yet, but we thought that it might be useful information for the rest. It's like a signature of the tumor growth. So we can spot with these curves in which stage of the growth we are. Okay, so now we just compare the growth of the virtual tumor and the real tumor. And so it's a first guess, because all these experiments that I'm showing to you I've just been finished in last September, so it's brand new results, so we still need to discuss the data. So as a first comparison of the two curves, so this is the growing curve virtual tumor. So the area for the virtual tumor is just the sum of the tumor cells. Since we have an automaton with all the elements the same size, we just count how many tumor cells we have in the elements, and we derive the area of the virtual tumor. And for the real tumor, what we do is just we make a segmentation of the tumor. So we go around and we have the overall shape. So it explains why it's initially much bigger, the real tumor, than the real one. Because in the 3D integration, the real system, it's a 3D integration of several layers of cells, whereas in the virtual one, it's just a 2D slice with just the tumor cells. So this is an artifact. In fact, it's not really a difference which is really real. But the real problem is more in this part. So this reveals a strong limitation of the model. What we have here is that the virtual cell is spreading into this. Since it is an automaton, then the cells, when they divide, they push each other, and then they expand in all the systems. Whereas in the real system, we have some compaction effect that we do not take into account at all in our systems. So that's why there is some divergence into these two curves above a certain amount of time. So it becomes really important above 4 weeks. So then, as I say, here is the best fit here, and somewhere in between 7 and 21 days. So we compared in this region some different tumor cases that we had. So the fluorescent images for the red channels are very difficult to make because we need an injection to the animal, so we cannot make it on a very regularly. So we have to make it about every week, not less than that. So that's why we have very few images with the two channels, green and red. So here we can compare the real tumor with so the scales are different. So that's why this one looks smaller than this one. But we can catch from D7, and we see that we have the shape is quite nicely evolving. And what we have is the angiogenesis developing here. And another thing which is interesting to notice is that we plotted here the VEGF diffusion around the tumor. And in fact, what we see here is that the background of the image is quite dark, and here it's more reddish. And it is due to the fact that the VEGF is creating some leakiness in the vessels. So it's the fact that we see VEGF here, it captures in a way the leakiness of the real tumor. So this is another case that we have. So here we see that the two parts are starting to connect together, and the angiogenesis occurring at the lower part. And another case. So here we see a very bright red spots, and this is due to some bleeding due to the manipulation of the mice. So yeah, but it disappeared 1 week later. Okay. And the last few cases. So in total, we had 4 mice with 2 ears, 1 tumor in each ear. So we had some 8 tumors, and only 1 tumor did not develop at all. So it was not a problem of the model; it was a experimental problem. But it happens. Okay. So at the end, so we took our 7 curves and plot them all together for the experiments and for the simulations. And what we see is so we normalized all the curves to make them all comparable, because all the tumors have not the same size and the same size. So the integral of each curve is 1 in this case. So when we all plot them together, we see that there is a specific point on day 17 where the curve seems to converge on this point. And when we do the same with the simulation, then it becomes very clear that there's something happening on this specific day, on day 17. So obviously it should come from, it's angiogenesis that is responsible for this, but we had to look at the data to exactly know what is happening on this day. And the interpretation that we made is that we have slower growing tumors, and these slower growing tumors, they catch up at the end, and the high growing tumor, they slow down. So there is a switch that is occurring somewhere due to angiogenesis, and the interpretation is that the slow growing tumor have a higher angiogenic potential, and this is due to the fact that they have a higher proportion of hypoxic cells. And reciprocally, we have exactly the symmetrical event. So that could explain why we have the convergence of the growth curve on this specific day. So, but to be sure, we had to look at the ratio of the proliferative and quiescent cells. And what we see is that we have here lots of proliferative cells, and then they come to quiescent state, and until day 14, and then after day 14, then we have the angiogenic transition. And then the oxygen is back to the tumor, and so we have some more proliferative cells appearing. So we have this transition, and day 17 is when really we start to have the return to proliferation of the tumor. So here I just show some low oxygen levels at day 7, and after day 14 we see that we have some bright patches responsible for the return to proliferation. So at the end, we want to do this model to apply some therapies. So unfortunately, I do not have any experiments to show you on the therapies because it's too early at this stage. We'll do that very soon. But I can show you some few results on therapies we made. So it's only simulations to see how it can work. So what we want to couple is vascular disrupting agent and cytotoxic molecules. So as a first step, we just apply them separately on the virtual tumor. So we add if we observe the tumor, then we see it growing for day 15, and this is the limit. After that, then we cannot follow our really. Okay, I'll be fast. So I finished that's the end of the experiments. So now we are only doing modeling. So without treatment, we see that the tumor can grow quite big. And the protocol can be defined with several choices. So the choice of the molecules, so the target phase. So if we choose a longer phase, then we optimize the chances to kill the tumor cells. We can also change the dose administered, the duration, and the frequency. And there's absolutely nothing surprising in all our results. What we discovered that when we apply the cytotoxic, then we can reduce the size of the tumor, in fact, which is good news. But yeah, what we see is that we need to make the maximum dose, the highest dose, to get rid of the tumor cells. If we don't use a dose high enough, then of course the tumor will keep growing. The same with the duration of the injections. So the most efficient are, of course, the longest injections. If the injection is too short, then we cannot get rid of the tumor cells. So nothing surprising. And another thing is the frequency of administrations. So every 3 or 7 days. So if we apply it every 3 days, then the 7 days the tumor will regrow. So we have a decrease in the amount of tumor cells, and then it's regrowing in between two treatments, and then it's going down again and go again. So we can keep it under certain limits, but still, if we stop the treatment, it will grow again. And if we apply it with a higher frequency, then we can more easily get rid of the tumor. And the last treatment we've been using is vascular disrupting agents. So we tried it on the mouse, and it's interesting what we saw. It's quite a spectacular result. Here, the action of VDAs are almost instantaneous. It takes a few seconds to act, and what these molecules are doing, they just shut down the flow. So what we see here, it's a brighter, it's a very bright part of the image. That's where the fluorescence has been stopped. So here the flow is, there's no flow anymore. The cells are immobile. And here what we see is the black stripes. It means that we have some flow. So it's a red blood cell flowing in the tube. So we see that some vessels are targeted, have been killed, and other vessels are not touched at all. So that's why it's very dangerous to use these treatments, because we don't really know what we are doing in the system. So here before VDA it's okay, and then here, for example, we destroy completely this structure. And then if we wait longer, we will observe massive necrosis in some part of the tumor, but not all of the tumor. So it will become more invasive and we will probably select more invasive phenotypes. So the whole point of the project is to try to derive something like this. So to use the virtual tumor to apply the VDA and see if we can predict in which configuration we are going to fall. If it's destruction, that's okay, it will be tumor death. If we manage to normalize the network, then we have to use the cytotoxic to maximize the effects. And if we have no effect, it can happen, then we have to go back to maybe reuse VDA and try to go into one of the two other situations. So this is a work in progress. So we are here in phase 1. So we have subcutaneous implantation of tumors in the ear of the mouse. And the model is mostly 2D in isotropic tissue. And what we use is a two-photon microscopy and immunohistology, and we have two means of actions. And the next steps we want to do is to bring it closer to the clinics, is to work on a rat this time, which is slightly bigger because we can have some, we can put some tumor in the brain, and we can use MRI images, which is closer to what we have in the clinic. And this time we need to develop the 3D part of the model with the anisotropic brain tissue this time. And we will use one more mean of therapy, which is radiotherapy. So we will have three interactions possible. So that's about where we are now. And to finish, I will just want to thank and acknowledge my partners. So I'm here in the Team C lab in Grenoble. And we work with people in Clinatech, which is a biomedical research center. That's where all the in vivo work has been done. We also work with the Institute of Neuroscience, and we are currently working on the second step of the project with the MRI images here. We have people from the automatic and control theory working with us. We are deriving the optimum strategy for the system. And of course, we are also working with a small company this company is developing some specifically antivascular molecules, so we are here to test them for them, and that's about it. Okay, thank you for your attention.
Okay, any questions for Angélique? Rachel.
Hi. I was interested in the effect of hypoxia on cell proliferation and survival. So I was interested in looking at this, and my biological collaborators had some results where they're looking at glioblastoma cells, and were finding that they could take the oxygen level down to really quite low levels, down to like 1%, and not finding any change in cell cycle. It was only when they took it down to say 0.1% they were able to get some transient sort of cell cycle arrest or cell death. So you commented that you adjusted the parameter for how oxygen levels affected proliferation. So I was wondering if you could comment a little bit more on that. What sort of levels of oxygen
so in the system it's all normalized for the moment, so we didn't try to connect this with real thresholds in hypoxia, but it's somewhere like four times less than normal cells, normal level. So we switch to quiescence when the oxygen falls four levels.
And do you think that is that representative of normal cells or tumor cells? Or
it's more representative of normal cells, not exactly tumor cells, but in fact tumor cells, they rely on they do a lot of glycolysis, so they do not use oxygen in fact. So they are not as affected as we put it in the model, and we know that it's a problem in our model. So now we are taking into account glycolysis as a competition with oxygen consumption. So we are aware that there is something to clarify in this direction. So yeah. Okay.
In your last slide, you showed the animal models you would like to look for, and there were different cell types you were using, 3 different cell types. How does a model account for different cell types? How?
Yes, as I said, it's in the parameters that we have been playing with. Okay, here. So we mainly act on these parameters. So we act on the cell cycle phase. So depending on the cell type, we might have some different duration for the cycle phase, and also for the threshold that we put into the model. So in fact, with just these 2 parameters, we are able to, for the moment, we have been able to match all our different type of tumors. Just playing with these ones.
Okay, we'll just take one more question, and then I'm sure Angélique will be happy to take other questions outside the course.
You also account for the effect on a normal tissue.
No, not explicitly, no.
That was nice and short. Bring to time. Yeah. So I think just in the interest of keeping the time, doing tea breaks and things, we should finish there for the formal part. As I say, I'm sure Angélique will answer your questions outside the talk. So just remains to thank Angélique for a really nice talk. Thank you very much.